Thank you very much, Jeet, for the kind invitation. Dr. Homograji has laid the ground for the realities and the possibilities that we have in Pakistan at the moment in terms of elimination. What I will try and do is give you some ideas of what is happening at the international level, particularly at the WHO level, because I've been involved with that exercise quite a bit. And that is basically focused on simplifying treatment and service delivery as much as possible so as to reach as many people as possible in order to eliminate the infection. So let's start with the WHO HCV guidelines, and there have been at least four iterations in the recent years: 2014, 2016, 2018, and 2022. It has been my distinct honor and privilege that I chaired the 2016, 2018, and 2022 guidelines for the WHO. And I think the biggest achievement that I would say and probably claim is that we managed to get the WHO to approve the soft DECLA combination as a pan-genotypic combination. And that has been the workhorse of our treatment in Pakistan. And no other society, major society, has soft DECLA as a pan-genotypic regimen except for WHO. And that is, I think that has been a major plus point because we've been able to use that leverage to be able to use soft DEC, which is, of course, the cheapest combination that we have. So just to show on this slide how simplification has happened. In 2016, we were still genotyping people. We were doing lots of various tests. We were treating adults more than 18 years of age. There were some restrictions and there were some preferences, not restrictions, but preferences. So we were treating preferentially people who had severe disease and leaving alone the ones who had mild disease for later. But then in 2018, this was the first time that it was treat all. And that made a major difference in terms of the speed of screening, of diagnosis, and of treatment. And the age went down to 12 years. And then in 2022, the major focus was on service delivery. And service delivery, the simplification of the service delivery, I think has been also a significant achievement, I would say, for these guidelines so that the elimination process can go on. There's been, in 2022, we also looked at the new testing that is coming in, the self-testing, et cetera, so that there is another way of improving screening. But in particular, what I want to talk about is the service delivery part, and that consists of mainly three things: decentralization that Huma has talked about already, integration, and task sharing. And so decentralization, as Huma has already said, is testing and treatment right down to the level of the community, as low as you can go, to their houses, to their clinics, to their BHUs, and so on. And that really makes a difference. Integration means that you start to integrate various other conditions, as Graham alluded to the fact that the Egyptian program started to measure blood pressure, diabetes, BMIs, so that they could get at least some handle on what NAFLD is looking like in their country, for example. There's a lot of obesity, as we know. Egyptians are our brothers and have a lot of truncal obesity like we do. Task sharing, and I'm sure that Dr. Leila Rizvi will talk about this, that we are no longer recommending treatment in the in the tertiary care hospitals or even in the district hospitals. This has to go down to the level, as lower level as far as possible. These treatments are simple, they are safe, and therefore anybody and everybody can be taught how to deliver these programs. Asad alluded to the fact that the ECHO program has made a real difference in educating, in re-educating, in building the confidence of people who are out in the community, so that they can do this in a more quick manner. So So just to talk a little bit about what the evidence says in terms of decentralization, this is just a classification, primary care, specialist care, etc., etc. And there was this systematic review that we looked at when we were looking at the decentralization process. And this is a forest plot which tells you very clearly that the most of the studies are favoring or heavily favoring decentralization. They are much more away from the central line, from the 0 point, and therefore the data was very clear that, and this is in fact the first one is full decentralization, which means that everything was happening on site, even the point of care, RNA testing, etc. Partial decentralization would mean that you would test the initial test from at the patient's house, but then you take the blood sample and you test the rapid the PCR test in a main lab. The decentralization and integration, particularly the integration that has particularly happened in these special populations. So just giving you examples of PIVIDs, of persons in prison, for example, full decentralization has really made a difference in the uptake of these patients. So this has been a key factor. Remember, these are highly infected patients and highly susceptible to reinfections and so on. So that has been helpful. Task sharing is just basically, just simply, very simply means, there's no big science about this, simply means that you take this out of the hand of the specialist and put it into the primary care. And finally, the concept of differentiated care. I think that is something also that people need to understand. There will be occasions and there will be patients who cannot be handled in a primary care setting. And if you're faced with this, you should have a pathway of giving these patients or taking these patients over into the next level, requiring a facility-based approach for various things, for decompensation, for liver cancers, etc., etc. So what has happened is, with the HCV simplification, certainly the numbers of patients screened and treated have gone up. This is slightly old data. This is 2019. More than 20% people screened. This is global, and about 13% people put on treatment. The numbers are much higher now for hepatitis C. But look at this. Look at what is happening for hepatitis B. Very, very few. Although we know that the burden of disease for hepatitis B is much, much higher. It is close to 300 million people infected. Out of those, only 10% by 2019 had been screened or diagnosed, and about 2 or 3% treated. So this is pathetic. Why was this happening? It was happening because the guidelines were or are still very restrictive. So I've just highlighted some points here from the various major guidelines, and you can see a DNA, a detectable DNA or a DNA level is a must for all of these guidelines to happen. And we know that this is the biggest stumbling block or the roadblock in terms of getting people to treatment as quickly as possible. So cirrhotics was somewhat better, less restrictions. But look at non-cirrhotics. The screen is full of restrictions. So in this, with this paradigm, there was no doubt, no wonder that people were not being screened, tested, and put on treatment for hepatitis B. And these are, and for all of these guidelines, there was a chapter or a table of who not to treat. So, you know, this was like like our policeman के आपने अगर पूछ लिया कि आप जा सकते हैं तो आप नहीं जा सकते, because why did you ask? So this is what the scenario has been, and I think this was the major reason why the WHO decided that they wanted to simplify these guidelines. And again, it was a pleasure and an honor, and I think an honor for the country, that I was one of the co-chairs for the guideline committee. We did this work in this year. and hopefully the guidelines will be out by October or November. We're trying very hard to get them out as soon as possible. So what was the need for these for expanding treatment criteria? I've already mentioned that because the guidance is perceived as very complex. There's increasing evidence on ongoing integration of hepatitis B. The more the time the patient spends with hepatitis B infection, the more it gets integrated. Ongoing horizontal and vertical transmission in those not on treatment, and therefore the cure agenda has been needs expanded treatment, and without that, really, we cannot cure hepatitis B or eliminate by 2030. So major steps are already happening. This is what the Chinese have done, and they can do it because they've got the money to do it. And this is very, very simplified approach to hepatitis B. So 81 million infections, nearly 30% of all HPV infections in the world, 6 million less than 30 years old, just have a detectable DNA. And you're on treatment. It doesn't really matter if, well, it does matter to some extent if you have these other features as well, but the main entry point is a detectable DNA and you get treated. For here, which is more than 30 years old, none of these parameters, just a detectable DNA, and you just treat, and that is it. So it's still DNA dependent. So I don't think this was something that we could adopt for a large number of LMIC countries. We really cannot. Many countries cannot just do a DNA on everybody that they wish to treat. So we looked at the expanded criteria, natural history of chronic infection by HPV DNA and ALT levels at baseline, the PICO2, and this is the way that WHO guidelines are structured, the efficacy of antiviral therapy at preventing clinical outcomes in HPV infected people at different baseline viral and ALT levels. So as I said, the guidelines are always backed up by very, very strong systematic reviews. So this was a systematic review on the outcomes, for example. So these are HPV DNA levels, and this is the outcome, HCC in adults. So I'm sorry you can't see maybe the small print, but as the levels go up, the HCC correlation certainly goes much higher. As the levels are down, actually it is a negative correlation if it is less than, let's say, 2,000 international units per ml. So that seems to be the cutoff where nothing very dramatic is going to happen. Similar data for cirrhosis in adults. It is a single time point HBV DNA, remember, so there are some caveats here. But as the levels go up more than 200,000, there's a very strong correlation in terms of the outcome. But levels lower, less than 2,000, most of these studies are to the left of the line, which means that they are negatively impacting. Lastly, single ALT assessment. Most of the studies, again, to the left. If you are more than twice the upper limit of normal, then you start to see some effect of the ALT, but not otherwise. So a single ALT assessment, incidence rates were highly heterogeneous. Multiple assessments, the less heterogeneous, a single ALT and HPV DNA assessment together, even less heterogeneous. We did a values and preference survey, and I'll just go through this quickly because I think this is interesting. This is a survey of providers that was done by ICE HBV. This is global. So the first question was chronic hepatitis B patients with advanced hepatic fibrosis should have top priority in receiving antiviral therapy. And no doubt across the board, 80% said yes, that is absolutely important. The next question was chronic hepatitis B patients with elevated ALT regardless of DNA level in the absence of other liver conditions. This is no DNA testing. Should they be treated? And again, the majority said yes, under those parameters, we would want these people treated. And then we said, look, hepatitis B infected patients, E antigen positive, normal ALT, now people are saying less and less. Maybe, well, we should do something else, we should not treat. Maybe less than 50% were saying, yes, we should treat. And finally, the question was, all hepatitis B negative adult patients should be routinely treated with antiviral therapy. Everybody who's surface antigen positive. And not many people, well, fortunately, not many people said yes, they should be, we should be treating everybody who's surface antigen positive. So that is a big question. Should we treat all surface antigen positive patients? That would be the real treat all for hepatitis B. But I think there are pros and cons. I don't have time to go into those pros and cons, but you can read them. It certainly seems that is still, we're still not there. We may be there in the next iteration, but we're still not there. So I'm not really supposed to show the slide because these kind of points towards the recommendations that are coming in. These are not yet approved, so it is not. Please don't disseminate this too much. But look at this. Just to give you a flavor, there's only one category where we have left a viral level, a viral load. All other categories are without a HPV DNA. So this is our attempt at trying to expand treatment modalities to these groups. So this is fibrosis, these are co-infections, comorbidities, and these are women of reproductive age who will be at risk of transmitting patients to the disease to their children. I'll skip this slide just in the interest of time. And also this one, these are just to conclude, hepatitis C is an example where simplification in multiple steps have made possible elimination of this infection. So really, Pakistan can eliminate this, as Huma showed the outline. If we stick to this, we can eliminate this in 2 or 3 years. And I would argue against Graham to say that we should tell WHO to give us a deadline of 3 years, not 2030, right? And measure everybody at 3 years and see what we do. And that is where we will act. Otherwise, we'll just sleep. The complexities in guidelines have prevented scale-up of treatment for hepatitis B. So I think hopefully we will have fixed that to quite an extent when the new guidelines come out. And therefore, all these steps will hopefully encourage the elimination of both hepatitis B and C by 2030. Thank you very much for your attention.
Thank you, sir.